And without further ado, let me begin. So here are my following disclosures. And before I talk about using saliva specimens to detect for respiratory infections, I think it's important to also just give a brief overview of respiratory infections. So respiratory infections make up the most common reason for people visiting healthcare as well as emergency departments. Transmission of respiratory infections can be due to contact with infected individuals, inhalation of aerosol droplets, and also through contact with contaminated fomites. Respiratory infections may cause both upper respiratory tract symptoms. Typically, those are symptoms seen in the vocal cords and above, and the related diseases include sinusitis, pharyngitis, and laryngitis, as well as lower respiratory tract symptoms. So these are symptoms that may cause bronchitis, bronchiolitis, as well as pneumonia. Some of the common symptoms may include fever, chills, fatigue, body aches, cough, runny nose, sore throat, change in taste and smell, and also a decrease in appetite. And in this figure here, you can see that those are some of the more common respiratory viruses that we are aware of. There are certain populations that are more susceptible to severe disease. So, for example, populations like individuals with suppressed immune systems, individuals with disabilities or comorbidities, individuals who are pregnant, and then also or older elderly adults. Those are the ones who are greater than 65 years old, and then also our children. So here are two graphs from the CDC from the United States where they actually stratify the data to look at the proportion of patients who actually go into the emergency department or being hospitalized due to respiratory illnesses. So in the top graph, you can see that a majority of the patients that go into the ED, especially in the winter months, are the pediatric population. So those are individuals who are less than 18 years old. On the bottom graph, when we look at the percentage of hospitalizations, you can see that both the elderly and then the very young, those who are less than 4 years old, make up a lot of the hospitalizations. So that is once again to support the idea that there are populations that are more susceptible. For the premise of the talk today, of course, we're more interested in pediatric populations. So infants are at increased risk due to their immature immune system, especially those who are getting treated for hematologic malignancies. Infections with influenza, parainfluenza, and RSV have been shown to have an increased risk of morbidity. There is an annual estimate of up to 80,000 children of less than 5 years old who are hospitalized due to RSV in the United States. So once again, the graph on the right, you can see from earlier this year in the winter, once again, those who are less than 5 years old make up for a lot of the hospitalization. Additionally, less than 5 years old have a higher risk of developing complications from influenza infection, and those who are less than 6 months old actually have a similar rate of hospitalization compared to the elderly due to COVID-19. So with that said, because there are populations that can develop into severe disease, it is very important to test for respiratory viral infections. There are implications to treatment as well as prognosis. It is possible to make this diagnosis just based on clinical symptoms. However, that can be very complicated. As many of us know, a lot of those symptoms can be very nonspecific. So hence, that is why you want a more sensitive and specific approach to tailor such treatment plans. There are several testing methodologies that are available for detection of respiratory viruses. So the table on the right summarizes really well some of the more popular methods. So when we're trying to detect for the viral antigen, a very popular method is the lateral flow antigen test. I think many of us are aware and have probably used one of these LFAs thanks to the COVID-19 pandemic. And of course, these are rapid, they're very inexpensive and very easy to use. The acceptable specimen types are usually nasal swabs. There's also direct fluorescent antibody testing to detect for viral antigen, but overall, I would say this is usually done in a clinical laboratory, and even in the clinical laboratory, many of us do not do that anymore. That's because the sensitivity is not so great. There's subjective interpretation, and it requires highly trained staff to actually look in a fluorescent scope to look for some kind of fluorescence. Another method that we are well aware of is PCR-based methodology. So anything that is like nucleic acid amplification technology. Um, These can be very rapid. They are also highly sensitive. There's a range of different platforms. So sometimes they could be singleplex versus multiplex, low to high throughput. There are some manufacturers that have a regulatory status to allow this to be CLIA waived or to be used at a point of care setting. So that is very beneficial for low resource settings as well. Something that I want to comment on is actually the range of specimen types that are being used using PCR technology. So obviously it includes your nasal swabs, NP swabs, and oropharyngeal swabs, but saliva is an added specimen type as well as sputum and BAL. So NP swabs generally have been the gold standard for detection of respiratory viruses. However, collection of an NP swab has to be done by a trained healthcare provider. And of course, many of us who have gotten an NP swab remember how discomforting that is. And also, as you're getting swabbed, sometimes we may actually resist the swabbing process, and that actually can lead to suboptimal specimen quality. So during the COVID-19, there were a lot of supply chain issues. Specifically, they didn't have enough swabs, there wasn't enough viral transport media. So that allowed us to think about alternative specimen types, such as saliva. Saliva as a specimen type is a lot better because it's not as invasive. Collection of saliva is not as uncomfortable. If anything, you can even self-collect, and then you may not need specific container types as long as you have a sterile container. So now the premise of the talk is regarding saliva in pediatric populations, right? And what I'm going to say is it's pretty messy. So saliva is messy, children can be messy, and then when we look at the data of saliva testing in children, it's kind of messy and hard to interpret. That is also because there are a lot of variables that are involved with doing these studies and also just analyzing the data. But I will say that after the COVID-19 pandemic, there is renewed interest in using saliva. So I think the field has very much progressed prior to COVID-19. So with that said, today I'm going to present some of the data that have been published as well as data that I have generated with regards to using saliva as a specimen type in pediatric populations. So let's start off with what do we know about using saliva as a specimen type for respiratory testing? Then this study was actually published prior to the COVID-19 pandemic back in 2008. So I would say this was a great proof of concept study to show that you can detect respiratory viruses such as RSV, influenza, parainfluenza, and adenovirus in saliva, although the performance is lower than NP swabs. So the accuracy of saliva here in this study was 74% compared to NP swab specimen, which was used as the gold standard. But what was interesting was that they were able to show that the time of collection from the onset of illness is crucial. So the accuracy actually goes up to 83% if you are testing the saliva within 3 days of onset of symptoms, and it actually drops to 65% accuracy if you're going to test greater than 3 days. So then fast forward now to post-pandemic, there are more studies now that have shown that you can use saliva to detect other types of respiratory viruses in addition to the ones that I just mentioned. So you have rhinovirus detection, Bulka virus, as well as the seasonal coronaviruses. But once again, in this particular study, they did show that performance is still lower than NP swab. So for any saliva that was tested, it was 76% compared to the 93% NP swab. But what was also interesting from the study was that the type of saliva specimens also matter. So they tested saliva swab versus just collecting saliva from drooling, as well as saliva collected on a sponge. And you can briefly see here that saliva that was collected using the drooling mechanism or a sponge tends to do better than saliva swab. So the type of saliva sample specimen type do matter. All right, so I alluded to that, the research landscape has expanded a lot after the COVID-19 pandemic. So what did we learn with regards to respiratory testing using saliva in pediatric populations, using SARS-CoV-2 virus as a vehicle to study? So here is a table consisting of the prominent studies where people have evaluated saliva specimen type in pediatrics. So just summarize for everybody because this is a busy table. Among these 6 studies, the sample size ranged from 18 individuals to 500. The population that were tested included a range of symptoms. We had those who were symptomatic as well as the asymptomatic individuals. Those include household contacts and other exposures. The specimen type, even though it is saliva, there were different specimen type containers. Some of these individuals, spit in a cup. There were the dribble pots, and there were also those who just collected saliva based on drooling. But most importantly, the platform for testing also varied. So different types of extraction methodologies were used as well as PCR test. It's good to keep all these limitations in mind because that could be a reason why, sometimes the accuracy and the performance may vary depending on the study that you're looking at. But most of us are probably interested in these 2 columns instead, and that is what is the sensitivity of saliva. So from these studies, it once again is a big range. We have a study here, although it was only 18 positive patients, the sensitivity was 52.9% compared to another study that had over 100 patients that showed it was over 96%. So there is definitely a big range. And some of the reasons why the sensitivity varied is because it does depend on whether or not we're testing symptomatic versus asymptomatic patients. Also, saliva positivity is dependent on the time of collection after post-symptoms onset. And then there were some studies describing the differences in CT values between saliva and NP swabs. So for the rest of my presentation, I'm going to just present some data supporting these points. So in this particular study, we actually evaluated the performance of saliva versus NP swabs in both pediatrics versus adults. What we saw was that saliva had comparable performance to NP swabs in first-time positive symptomatic pediatric patients. So you can see here in first-time positive pediatric patients, in saliva, we achieved a positive percent agreement of 82.4% compared to the 85% in NP swab. So this is just a difference of 1 patient. However, when we looked at all positive, so now we're including all the asymptomatic individuals, this gap in performance is a lot bigger. So saliva accuracy was 79% compared to NP swabs of 88%. Interestingly, though, when we looked at the adult population, despite it being first-time symptomatic adults, the performance of saliva was only 80% compared to the 91% achieved by NP swabs. Something else to note was in our study, we actually saw that there were additional 10 cases for COVID-19 that were caught by saliva that were negative by NP swabs. So this justifies that one, saliva can be an acceptable specimen type, and two, many of us always say NP swabs is the gold standard, but this kind of challenges the idea that maybe NP swabs are not as perfect as we thought they were. Something else that researchers have looked at is the ability to detect the SARS-CoV-2 nucleic acid material over the course of infection over many days, even up to months. So this is a study that was done to predict and evaluate the viral load in specimens up to 1 month after symptoms onset. So what they were able to show was that in NP swabs, based on the predictive modeling, you can still detect viral nucleic acid material up to 1 month. However, if this was from a saliva specimen, it seems like the cutoff is a little less than 2 weeks. However, they did have 1 patient who was symptomatic, and they were able to actually detect nucleic acid material up to 20 days post-symptoms onset. And this was actually a finding that we were also able to replicate in our patient population as well. So in our pediatric population, when we mapped out detection of NP swab versus saliva, we saw that we were actually able to detect viral loads in specimens that were collected post 20 days after symptoms onset. And then in the adult population, actually, we were actually able to detect viruses even after post 40 days symptoms onset. So once again, this shows that saliva specimens can be stable as well for testing. Another thing that people looked into was the difference in the CT values between saliva versus NP swab specimens. So the study on the left actually looked into the CT values of three different genes for SARS-CoV-2, the E gene, RDRP, and the N gene. Overall, doesn't matter which gene it was, they actually were able to show that the CT values for the NP swabs were lower than the CT values achieved by the saliva specimen. However, in our particular study, we actually saw that there was no statistical significant difference. If anything, the CT values in the NP swabs had an average of 29.1, which is zero point 0.4 higher than the saliva specimens, actually. But something to note is that we used an assay that detected for the N, S, as well as the open reading frame 1AB gene. So there could be some differences in the methodologies that we used. But overall, this is to say, there could be differences in the CT values between the two specimen types. They may not be exactly identical, and the range can be anywhere from 0.4 to 3. Saliva sensitivity, most recently in this very recently published paper, shows that it could change depending on the variant as well. So in this study where they looked at 548 paired specimens with both positive NP swabs and saliva, they saw that the sensitivity was highest when they were testing for the Delta variant of SARS-CoV-2. And then this difference between the pre-Delta and the Omicron variants were statistically significant. But what was once again interesting was that regardless of what variant it was, the sensitivity is still higher in symptomatic individuals compared to non-symptomatic individuals. So once again, this is a recurrent theme. So as somebody who has worked with saliva, I think a lot of us can also agree that saliva can be very messy. It can be very viscous, mucousy. So then the extraction platform really does also increase the sensitivity. So in this particular study, they looked at extraction using proteinase K, where they actually added it to the saliva specimen and then vortexed it vigorously to show that they were actually able to increase the sensitivity and accuracy past 98.9%. So the sensitivity was 94 compared to the specificity of 100%. So extraction platforms do matter when we are evaluating the data. So even though saliva may perform slightly less sensitive than NP swabs, it may still be an ideal option for surveillance if there is frequent testing. So the idea that because you're sequentially testing and you're testing a lot of times, that could compensate for the lower sensitivity because eventually, if the patient does turn positive, you will capture it. And for children, they may be more willing then to participate in surveillance studies because it is not as painful as getting swabbed. And most importantly, there have been a lot of epidemiological and sequencing studies to show that the SARS-CoV-2 genomes can be completed with great accuracy compared to NP swabs if they are obtained from saliva specimens as well. So that is to say you can use saliva to perform outbreak investigations. So as I was preparing this presentation, I was looking into, surveillance or testing programs using saliva, and I came across the Sick Kids Saliva Testing Program. I am by no means affiliated with this program, but what I thought was cool was that this program is offering saliva test kits, known as spit kits, to symptomatic students and staff to test for influenza, RSV, and COVID-19 at select schools across the Toronto area. So in the beginning, they only did this for COVID-19, but in this academic year, they are expanding it to other respiratory viruses. So this is a program that really brings, what we've been all trying to achieve with saliva testing into a reality. There are other applications for saliva testing. So I mainly only talked about the detection of pathogen, but you can also use saliva to measure an individual's immunity. So saliva as a specimen may also contain secreted or serum-derived immunoglobulins, which is a measurement of immune status. And there are plenty of studies that have shown that you can use saliva as a specimen type to perform measles serology, pertussis serology, and then you can also use it to measure antibody titers against vaccinations such as the post-meningococcal vaccine, as well as vaccination for Haemophilus influenza and the live attenuated influenza vaccine. So in conclusions, there are many benefits to using saliva as a specimen type for pediatric testing, such as the ease of specimen collection, being non-invasive, having low cost, and then of course you can avoid supply chain issues. The literature is scarce, but I think the data is promising, supporting the utility of respiratory testing in children. There are different factors that can affect accuracy and variation in results, such as symptomatic status, the type of collection containers, the viral target, and the respective variants depending on the virus, and then as well as pre-testing storage conditions and specimen processing. Even in NP paired collections, sometimes there are instances where it's only saliva positive, so it further supports the fact that saliva is a proper specimen type. And then, despite the lower sensitivity, frequent testing may compensate for that. So hopefully there are further investment in saliva diagnostic development. I think one of another benefit that people don't talk about a lot is that you can use saliva and adapt it to low resource settings or point of care settings. That way you can increase health equity and also community testing programs. So with that, thank you all for your attention, and I'm happy to pass the stage on to our next speaker.
Thank you, Dr. Yi. Really appreciate the thoughts and the conversation that I think you sparked, at least in my own mind, and potentially for some follow-on for us to do. Please, for those that are attending, if you have questions, put them in the chat. You can direct them to me using the Saliva Direct messaging option. And I'm happy to keep an eye on those while we have this time set aside for our Q&A. Dr. Yi, some questions that came to my mind while we're, actually, we already have a question that came in. So one of the questions for you, Dr. Yi, is do we have an optimized collection and processing for saliva serology, known antibody detections with different saliva samples?
The quick answer is no, we do not have an optimized method. Definitely not for serology, and even for PCR, there are a range of different methods to collect, and that is something that a lot of proponents for saliva diagnostics are saying that we need to generate an optimized method for collection and even specimen processing. There are kits that are available, but every kit is a little different.
Yeah. It's interesting. That was the first question that I had noted over to the side was you shared collection is messy, especially with pediatric populations. And so I was also curious about what methods were more useful than others as you shared and where you see opportunities for improving the efficiency of kids to be able to maybe collect their own samples. Is that something that your team is working on or just looking at after the sample's been collected, doing the diagnostic side of it?
I'm more interested in the diagnostic side of things, so after specimen collection, but I do think it's worth the investment. And not only should people work on standardizing the method, but there should be more published guidelines on how to, use these specimen collection containers.
Absolutely. Absolutely. One of the questions related to this, and please, for those in the audience, feel free to keep putting those questions in the chat. One of the other questions that I had thought of is previous presenters on this webinar series have shared about the potential for offering at-home collection or self-collection by kids. And so I was curious if that's something that you see as a few years out on the horizon or maybe sooner based on the work that your team is doing and what you've seen in the literature.
I do think it is definitely on the horizon. Recently, you're not just simply with saliva, but there has been a push for self-collection, even for like STD testing. So I do think that is something that's on the mind of for a lot of people. So I could see this definitely happening.
Great, thank you. And one other question that I had, and I don't mean to monopolize this, but as we're waiting for others maybe to come through, is what's next for your research? You've been doing a lot of amazing work with respiratory targets and things like that. What other targets are on the radar for you and your team for pediatric populations?
So something that I am interested is bacterial detection mechanisms or technology. So that's something that I've always been interested in. And then, for example, tying it back to saliva, one way to detect for bacteria is also using saliva. There have been plenty of studies that show that you can use saliva to test for like Neisseria colonization as well as strep pneumo detection. So I'm more interested in now the bacterial side as well as the antimicrobial resistance side of things.
Amazing. Amazing. Well, perhaps if there's anyone who's joined this call and conversation and that's also of interest to them, there's some opportunities for networking and maybe some collaboration or sample sharing. Really appreciate your presentation, Dr. Yi, and a lot of the topics that you mentioned in terms of just increasing awareness and looking into it and doing those kinds of pieces to advance more accessible diagnostics is something that obviously really resonates with our team at Saliva Direct. And I've made a note to look into that Sick Kids Test Kit program you mentioned up in Canada. That's
Yeah.
something that I think really aligns with what we are exploring as options. And if you don't mind, we have one more question that just came in. And that's, can we test IL-6 and IL-8 in a pediatric patient as pro-inflammatory biomarkers using a saliva blood ELISA method?
That I am unsure about. I'm so sorry. Yeah. I don't know the answer to that. I mean, I think those are definitely good markers. We definitely use that for like blood testing, but I am not sure how it applies to saliva.
Thank you so much, Doctor. You really appreciate your presentation. And if there are any additional questions from the audience, oh, we got a note that says the Salometrics testing lab can test for IL-6 and IL-8. So it looks like there's a potential connection there that we can make. I'll take a screenshot of this one so I can connect you to after this call.
There you go.
Perfect. See that the joys of these kinds of networking opportunities. You never know who's going to also be on the conversation. All right, and then we got to thank you. So fantastic. All right. Well, Dr. Yu, really appreciate it. If there are any additional questions that you all think of for Dr. Yu, please feel free to continue putting those in the chat. And if there's time at the end, we can circle back, or I'll make sure that they get sent over to Dr. Yi after today's webinar is concluded. With that, we'll shift over to our next presenter, Dr. Robinson Sabino Silva. He is a professor of physiology at the Federal University of Umberlandia and Innovation Center in Salivary Diagnostics and Nanobiotechnology. Dr. Robinson is a professor and researcher and specializes in saliva-based diagnostics. Excuse me.
Thank you for the kind introduction and for having me here. I would like to thank Saliva Direct for the opportunity to share our work with developing in the saliva nano with researchers worldwide. And today I will present our research on salivary diagnostic platform and innovative on-demand bioactive molecules targeting emerging disease supported by AI strategies. We have some potential conflict of interest because we have 17 filed patents in the National Institute of Industrial Property. And our main line of research is to select bioactive molecules using bioinformatic together with AI. We name it SagaPep. Phage display technology, and sometimes we use it functionalization with nanoparticles. After select these bioactive molecules, we try to introduce these molecules in electrochemical biosensor and lateral flow biosensor. And we have also developed some mass spectrometry sensors and some photonic biosensor. And our bioactive molecules may be also applied to novel therapeutic approach. As I told you, our main research line includes the development of the bioactive molecules selected through the bioinformatic, sometimes integrated with the artificial intelligence. And also we have used phage display and functionalization with nanoparticles. We try to insert these selected bioactive molecules in electrochemical biosensors, lateral flow biosensor, and we have also developed mass spectrometry sensor and photonic biosensor. Besides, our bioactive molecules may be applied to novel therapeutic approach. Please, next one. And today, we know that current diagnostics are based on the blood samples or nasopharyngeal swabs, which are invasive and uncomfortable for the patient, as well as costly reagents that may be scarce in the less developed countries. Furthermore, conventional methods generate significant biological waste, such as needles, syringe, gloves, masks, carcinogenic reagents, incineration, several pathogens, and contamination of the groundwater used in their agriculture. Next one, please. We know that saliva is regulated by parasympathetic and sympathetic activity, and that these salivary glands have a rich blood supply, thus allowing for the expression of thousands of potential salivary biomarkers. Next one, please. As we know here, we have 1,000 of peptides, proteins, and messenger RNAs in saliva, and we have hundreds of lipids, carbohydrates, metabolites, several species of microorganisms, illegal drugs, and several ions and other organic molecules. As we know, salivary diagnostics is a non-invasive, economic, and painless, easy to transport, that do not coagulate and can permit self-collection without trained profession to collect sample. However, these tests have some translational and clinical challenges. Next one, please. As we know in the figure, we can understand that saliva can provide a drastic reduction in the environmental impact. Next one, please. Our research has been conducted using metastatic, chronic, neurological, respiratory infection, and toxicological disease. And this is connected due to the intense connection of the blood and salivary glands. Sorry, I believe that when I send the other PowerPoint mode, some changes occur here. But we have in the right side, in the left side, the several diseases that we have worked. And in the picture below, we have the image of the diagnostic platforms that I will present in this talk. Next one, please. In the first study, we aimed to select naturally occurring salivary peptides that interact with the RBD motif of the SARS-CoV-2 spike protein. And it is known that the RBD interaction with the ACE2 receptor that is distributed in the oral cavity can enable viral replication. In this image, our hypothesis was that high affinity interaction between salivary peptides that the RBD domain can prevent SARS-CoV-2 and replication. Because if this salivary peptide block the connection of the SARS-CoV-2 with ACE2, we do not have this replication. Next one, please. To test our hypothesis, we used a peptide databases with more than 2,000 salivary peptides, and we selected the 300 best peptides and conducted 100 of bioinformatic dockings of these salivary peptides with our target. We selected the 4 peptides with the highest binding energy, and their antiviral capacity was tested in the BSL-3 labs against Wuhan, Gamma, and Omicron variants. Next one, please. Here we can see the image of 2D and 3D docking representation. In gold, we have the SARS-CoV-2, and we have also the peptides here to show the connection. Next one, please. In this case, 3 naturally occurring salivary peptides showing no cytotoxicity and reduced the infection with SARS-CoV-2 pseudovirus. Next one. And we have also demonstrated that these salivary peptides can reduce SARS-CoV-2 expression in the Gamma and Omicron variant. Thus, we conclude that this bioinformatic workflow was able to select salivary peptide. And when we inserted this salivary peptide, we know that it inhibits SARS-CoV-2 infection, and due to the low toxicity, it allows application to the prophylactic strategy for the COVID-19 in oral care products. Next one, please. Here, we can see our BioInspirit artificial intelligence approach, named SagaPep. It is designed to select bioactive molecules more quickly to faster drug development. And in this case, we target the same RBD domain of SARS-CoV-2 and performing dockings with the salivary peptides. And based on these results, we trained artificial intelligence algorithms, specifically one surrogate assistant genetic algorithms, to suggest new sequence based on these new dockings. These peptides were modeled in the AlphaFold, and we showed increased binding affinity with the target molecule. Next one, please. Here we can see in green triangles that it occurred increased binding energy when we used this SagaPep and indicating a greater binding energy as shown in the color green. Next one, please. Thus, when we use these SAGA-PEP bioinspired peptides, we can see that we have an increased activity in the reduction of the SARS-CoV-2 replication in this culture of cells. Next one, please. After that, it is known that the norovirus infects around 1 billion people worldwide, and saliva can transmit norovirus even in the absence of diarrhea. And in that case, in collaboration with NIH researchers, we tested our SAGA-PEP platform for a norovirus diagnosis. Next one, please. We selected, in that case, 3 salivary peptides based in the first part of the SAGA-PEP. And next one, please. We have inserted firstly some gold nanoparticles in the electrodes, and after that we have performed the functionalization with the salivary peptides to targeting MNV1 of norovirus. After that, we can try these electrodes in our electrochemical devices. Next one, please. Here we can see that this electrochemical assay was able to detect around 87% of the accuracy to detect this norovirus in the saliva of the mice infected with this virus. Next one, please. Besides, another strategy that we have used is using the phage display technology. In that case, we have tried to select some molecules that were used to the immunoglobulin A assay reactive to the HPV salivary diagnosis. And in that case, we have getting around 87% of the accuracy in these tests. Next one, please. This is another strategy. In that case, we have used this magnetic assay, and it is good because it is can impact and perform. If you can text in it is a video. Oh, no, that's okay. The next one is it's a video, and we can see that this magnetic assay can increase the sensitivity of our platform. Now I will talk about our sustainable saliva-based diagnostic platform. Next one, please. And we try to develop a different word. Today we have several West in the world, and we think that using the ATR-FTIR, that is a technology with a reagent-free analysis, it is a sustainable, cost-effective, rapid, simple to prepare, and reproducible. We can have a better word. Next one. Here, it is a study that was published in the Nature Protocols, and we can see that in one single analysis, we can detect the presence of the vibrational modes related to lipid, protein, nucleic acid, and carbohydrates. Next one, please. This is the platform that we have tried to use here. And with a self-collection with saliva, we can have the proteins, RNAs, virus, and bacteria in 1 microliter of saliva. And we can insert just 1 microliter in the ATR-FTIR platform. And with just one spectra, we will have 1,000 of potential biomarkers in one test. And we send this spectra to artificial intelligence algorithms that can be work 24 hours per day, 7 days per week. And after that, we can send this data from the smartphone of the patients. Next one, please. We have used several artificial intelligence algorithms together with other groups in our university. And in the last month, we tried to also test some deep learning algorithms and LLM strategies. Next one. In this model, we infected some mice with Zika virus. We can see in the right side that these mice were infected based on the Zika virus mRNA expression. Next one. And in this example, we can see in the black line that we have one presence of the spectra of the control mice, and in the Zika mice we have changes in these spectra. And when we send this spectra to the LDA SVM analysis, we detected a presence of the with one accuracy of 100%. Next one, please. When we performed a similar test using chikungunya virus, we also have able to detect this chikungunya virus infection using saliva. And as you can see here, we have a difference in the spectra of the control and chikungunya virus. Next one, please. And in that case, we can see that we have changes in the lipid profile of saliva, the protein profile of saliva, and some nucleic and carbohydrates components. When we apply the artificial intelligence algorithms, in that case is a supporting vector machine, we have 85% of accuracy in this vibrational mode using to this AI strategy is based mainly in the protein expression. Next one. In that case, we have used it to detect enterovirus that we have inserted it in saliva, and we have in this case detected just in 70% using one AdaBoost algorithms. Next one, please. We have also tested to detect Helicobacter pylori in the saliva because it is associated with gastric cancer, and in that case we have a several concentration. Next one, and we were able to detect this Helicobacter pylori in between 85 to 93% of accuracy in that case. And in all cases, we can also describe the specific molecule detected in the saliva to discriminate this sample. Next one, please. In that case, we have used the same platform to detect Toxoplasma gondii, and we were also able to detect this important acute infection with 95% of accuracy. Next one, please. And in that case, it's a different case. We have used it together with the Federal Police in Brazil. We inserted crack cocaine, and these rats smoked this crack cocaine. And after that, we also can see in the black line and the red line a difference in the expression of these metabolites. Next one. And we have were able to detect the presence of the crack cocaine with 90% of accuracy. Next one, please. In this case, we have tried in the diabetic patients, our first work. We have around 70 subjects, and we were able to detect the presence of the diabetes in 87% of accuracy. Thus, as we can see in the right side, the changes were related with phospholipids, proteins, and also DNA. Thus, next one, we have also tried in the large sample, using in that case more than 200 samples, and our novel neural network were able to detect around 85% of accuracy the presence of diabetes using saliva. Next one, please. And we can see here that we have a test in the several disease that I don't have time to talk today, but maybe we can talk in another opportunity. Next one, please. And sometimes we have used gold nanoparticles that can be coupled with the Zika virus infected mice. And in that case, we can see in the red line that we were able to see better the lipid biomarkers in the FTR spectra. Next one, please. And this is one paper that we have published in February of 2020. This paper has more than 1,000 of citation, and we described the coronavirus impacts to dentistry and the potential of salivary diagnosis. Next one, please. And after that, with 1 year of pandemic, we performed a review, and that in that review we have substantial salivary detection of the SARS-CoV-2 in patients with a negative nasopharyngeal swab around 12%, indicating one expressive indication of false negative results comparing with the gold standard species. Next one, please. And in this year, we have published a systematic review and meta-analysis of the diagnostic accuracy using pirate nasopharyngeal swab and saliva, and we detected a similar sensitivity and a similar accuracy for both specimens. Next one, please. This is another test using the electrochemical biosensors. In that case, we have also tried to send the electrochemical spectra to the artificial intelligence algorithms to send the data to the smartphone of the patients. Next one, please. And next one, please. Okay, and we can see here that in blue line, in the black line, we have the data from the controls, and in the red line, we have the data from the COVID-19 patients, and we have, in this case, detected with the 70% of accuracy. And but when we inserted our artificial intelligence algorithms, we have able to detect 85% of accuracy. Next one, please. And this test we have performed in the laboratory of nanotechnology, and we have tried to insert our bioactive molecules to develop novel lateral flow assays from several diseases. Next one. And in that case, we have used salivary lipidomic. And the next one, using this salivary lipidomic, we try to detect a difference in the autism spectrum disorder. And we have filtered 27 lipids that have an expression of more than 75% in one group. And when we send this data, we detected 3 salivary peptides that, salivary lipids that were able to detect a differentially expressed metabolite here. And next one, when we have send this data for our artificial intelligence algorithms, this lipid can be able to detect autism spectrum disorder with 84% of accuracy. Next one. This is a novel test that we were working here today, and we have used it to detect saliva using metabolomics. Next one. And in that case, in the patients with the long COVID-19, we have able to detect in around 80%, and we have detected several salivary metabolites that are differentially expressed in the long COVID infection. Next one. This is other reviews that we have published about the relevance of the dentistry and the omics perspectives in the monkeypox disease. And the next one is a similar in the Chapari virus that was present here. Next one. And this is what moves us. Based on the other colleagues, as Professor David Wong, we have we can imagine a new horizon where a visit to a dentist can diagnose systemic disease. And we can imagine a new horizon where physicians can diagnose several diseases with a drop of saliva. And in this horizon, salivary diagnosis can save billions of dollars using inexpensive procedure. And we work to make this dream a reality with our novel salivary platforms coupled to the AI strategies. Next one. This is our team with several postdocs and PhD students and Master in Science students. Next one. Other picture of our team. Next one. This is the financial support that we receive in Brazil. And the last one, our contacts, if anyone can contact with me. Thank you so much. Sorry for the problem for me is working good here, but unfortunately is not for all.
Oh, thank you so much for that wonderful presentation. And thank you everyone for staying a few minutes longer to be able to hear all of that information. We've got one question that came through is, does your team perform any saliva pre-processing prior to FTIR analysis?
Okay. Normally, we don't use any pre-processing because we trying to insert saliva without several pre-processing, because in Brazil it is very important if we can have a platform that in that case it's a portable platform, and we can send this portable platform from different parts of the country. And in some cases we don't have a centrifuge, and because this normally we don't try to perform several pre-processing.
Thank you. Again, please feel free to put those questions over in the chat. One that came to my mind, my background's actually in environmental science. And so you talking about making this more sustainable really stood out to me. And so I was curious if you'd share some examples of how your team's advancing that sustainability in your work.
Okay. For us, the sustainability is very important. And in my point of view, the main advances is related with the use of this biophotonic platform, because we do not need insert any reagent to perform this analysis. And because this, we can improve our sustainability, because I believe that this is the main point. And we have several other tests also with urine and also with blood inserted in the same platform. And we have very good results for different disease. And sometimes with 400 patients and 300 patients with urine in that case. And I believe that it is very important to maybe we can clean the world.
Thank you. Thank you. Appreciate that. A question that came in is, did you use any preservative while collecting the saliva or in transporting it to lab?
Okay. When we perform some test to detect RNA or protein specific, we need some reagents to do it. But to this biophotonic platform, we do not insert any other reagent, because if I insert any reagent, I will see the spectra of this new reagent that I insert in the sample. Because this, we prefer use just saliva.
Thank you. One last question that was on my radar, at least, was I've been seeing a lot from our fellow folks in the network about the use of AI in diagnostics. And you mentioned that that's something that your team is doing. Would you mind speaking to how you're utilizing AI to do the analysis or process data, and where it applies in your work?
Okay. There are several AI strategies to do, and there are some strategies that are free programs in the internet, and we have some Python-based algorithms together with colleagues from the other groups in the university that and we send the spectra, the data of the spectra, and after that we can perform this analysis.
Wonderful. Thank you. It's great to have that kind of cross collaboration, be able to pull into multiple disciplines to advance the science. Really
Yes.
appreciate it. Well, again, thank you to both of our presenters, Dr. Yi and Dr. Sabino Silva. Really appreciate you sharing about your work and your research. I've got some follow-ups of my own, and perhaps others who have joined us today will as well. It seems like there's some great interest from the chat, that there's some questions that might still be coming your way. For those of you who have attended, please keep an eye out for the recording of today's presentation and the overall webinar, as well as if you're interested in receiving PACE credit, there'll be that survey that'll be coming your way again. Really appreciate everyone taking the time to join us, and looking forward to seeing you all at the next installment of this diagnostics webinar, which will be in the new year. So we'll see you all back in 2025.